academic insights in healthcare, the recent advances that are coming up with everyone. And in this regard, so today we have a webinar on changing lives and saving brains through advanced brain technologies. And the esteemed panelists are Professor Christine Roffey. She's a stroke physician at the Royal Stoke University Hospital and professor of stroke medicine. She leads the UK National Institute for Health Research Hyperacute Stroke Research Center Oversight Group. Welcome, Professor Christine.
Oh, thank you.
And
thank you very much.
Dr. Sanjeev Nayak. Dr. Sanjeev Nayak is a consultant interventional neuroradiologist at the University Hospitals of North Midlands. He's one of the first and foremost pioneer of mechanical thrombectomy in acute ischemic stroke in the United Kingdom. Welcome, Dr. Sanjeev.
Thank you.
And then we have Dr. Kiran. He's a senior consultant and head of neurosurgery department at Narayana Health City, Bangalore. And he has a special interest and expertise in skull base and spine surgery and has shared this all over the world through conferences, publications, and mentoring programs. So welcome, Dr. Kiran.
Thank you. Thank you.
Without further ado, I would hand over the stage to Professor Christine to take us through her presentation and enlighten us. Over to you, Professor Christine.
Thank you very much for inviting me to Hyderabad. I just wish I was there in person. I'm sure it's going to be much warmer there, and the discussion is always nicer when you see people. Here's my declarations. Main thing is that I chair the Hyperacute Stroke Research Centre Oversight Group, so I've got a particular interest in stroke research. My topic today is to talk about all the things which aren't quite technology, i.e. Not thrombectomy and not surgery. So what else is stroke care about other than doing these very highly technological intervention? And we've got to say that over the last 20 years, mortality and prognosis from stroke has massively improved. And this has happened through the development of stroke units. In the late 90s, there's been a Cochrane systematic review which showed that there was a significant reduction in mortality with stroke units, and that has been confirmed in sequential and more recent meta-analyses. So just to have a patient on a stroke unit reduces the chance of death by a quarter. The number needed to treat to prevent one death is 2. So it's a very effective treatment. And in competition with Dr. Nayak, who's speaking later, that is actually a better way to prevent death than thrombectomy is. Similarly, if you're looking at prevention of patients being admitted to care homes, number needed to prevent one admission to a care home is 6, and to prevent dependency, the number needed to treat is 6. So stroke unit care is highly effective intervention. But then if we look at stroke unit care, you want to know, what is stroke unit care? What do we actually do on these stroke units to save lives and make patients better? And I've just got a few pictures here of different types of stroke units. On the left, less highly technological. On the right, clearly high-tech, high-vis stroke units. So when we're talking about stroke unit care, what does it actually mean? What are we doing? If you look at the meta-analyses, which were the start of the stroke unit movement, you see that all of them are pretty old. The latest is 2004. That means all the evidence we've got for stroke units actually precedes thrombectomy and also precedes thrombolysis. Leaves us to think what is done on stroke units makes a difference. I've tried to, there is no clear evidence about that, but I tried to get as much evidence as I could and summarize this in 12 key points. So the black box of the stroke unit, what do we have to put in to make it work? And I think, while I said at the beginning that hyperacute, I wouldn't talk too much about hyperacute stroke management, clearly nowadays there's no way we wouldn't provide that sort of treatment. So really important in stroke care, stroke unit care, is early diagnosis, provision of recanalization treatments, be that thrombectomy or thrombolysis, just as importantly, for those who've got hemorrhages, management of brain hemorrhage with with reversal of clotting problems and blood pressure management. And often forgotten, because we call them stroke units, is the diagnosis and management of stroke mimics. In addition to the hyperacute care, we have things which are slightly slower, but not much slower. And I think the second most important aspect of stroke care is the early start of secondary prevention. And the evidence for this dates back to 1997 for the first IST study, and the first stroke mega trial, which involved 19,000 patients and showed that prophylactic anticoagulation did not prevent strokes or improve recovery, but aspirin did, and they were using aspirin 300 milligrams for the first 14 days. And this is what most guidelines worldwide are now based on. Give aspirin early for strokes. And a further meta-analysis looking at other studies as well confirmed that aspirin reduced the recurrence rate by 6 weeks by 60%. It reduces the severity of recurrent strokes, and the greatest benefit is there when it's given early. More recent studies have also shown that dual antiplatelet therapy given early for patients with minor strokes or TIAs is even more effective, and most studies have used a combination of aspirin and clopidogrel. And still under research is to see whether giving anticoagulation for those patients who've got atrial fibrillation earlier rather than the currently recommended 2 weeks would also be of benefit. There are 2 trials ongoing. We're participating in both the ELAN and the Optimus study. Often forgotten, because I assume most of the audience here are doctors, and we feel that we make a great big difference about the lives of patients, are the nurses. There's quite a bit of evidence that the quality and quantity of nursing care has a direct impact on outcomes. If you look at the curve here on the top right, it's taken from the UK stroke register, basically a registry of all strokes admitted to UK hospitals, and they analysed nursing levels against outcomes and found that nursing levels at the weekend, depending on whether they're well staffed or not so well staffed, mortality could range from 11% in the best staffed hospitals to 15% in the worst staffed hospitals. That was just nurse staffing, so it makes a big difference. So what do these nurses do? And on the left, I've got a list of various interventions nurses are involved with. But again, these are things we see. But if you want to have evidence for it, you look at the FES study that was published in 2011 in the Lancet by an Australian group led by Sandy Middleton. And it shows that a systematic intervention of controlling fever, sugar levels, and assessing dysphagia and managing dysphagia was highly effective in reducing death and disability. And again, if you compare it with thrombectomy, where the number needed to treat to save 1 patient from death and disability is about 4, you've got the number needed to treat here for this nursing intervention, which is 6. So you treat 6 and you prevent 1 patient having death and disability. So highly effective intervention. Nutrition clearly is a key to survival and is a key to quality of life and to outcomes. This study, which, and I suppose we all know about that because we all don't want to live without food, but in stroke there's always been the worry, if we feed too early and the patients are dysphagic, could we start off pneumonias? Could we start off aspiration? When is the best time to start in those who've got swallowing problems? And the food study addressed that in 2005, and they were looking at different aspects. And outcome was that oral route, wherever possible, is best. If nasogastric feeding is required, it's best to start it early. It was associated with better survival. But if the swallowing problem persists for a long time, we initially wondered whether starting the nasogastric tube earlier would be better, rather starting the gastroscopy tube earlier would be better than having prolonged nasogastric feeding. But this study showed that it is better to delay gastrostomies by 3 to 4 weeks. It's quite unclear why that is the case, but part of it may be all the other changes in management which come with having the tube in place. And certainly in the UK, that often means once a PEG tube is in place, the patient is ready for transfer to a care home, which then obviously has less care levels and less rehabilitation levels. So it may be that's the secondary effects which are that, rather than the tube itself, which has an adverse effect. So feeding, nutrition is very important. Early mobilization. Aspect of all stroke unit definitions is early mobilization, and there've been a number of studies which have shown that early mobilization reduces complications, halves complications, and reduces adverse outcomes. Once we had that evidence, and once it started shaping stroke units, getting patients out of bed, getting them moving early, the next idea is let's do even more of it and do it even earlier. Early mobilization has always been seen as something within 24 to 48 hours. Very early intensive mobilization is within less than 24 hours, and it is intensive. And in this particular trial, it was up to 45 minutes a day. And the scientific community was quite surprised to find that no benefits were found from this very early intervention, and that outcomes were actually worse for those patients with severe strokes. That doesn't mean that early rehabilitation mobilization is now out, because this particular study didn't compare very early with late, but very early with early. So we still find that the evidence is best for patients to be mobilized early rather than very early. And early, as shows here on this table, this meta-analysis, the best time is within 18 to 24 hours. So start the rehabilitation really on the first, if not on the second day, but don't delay it any more than that. Continuous monitoring is important. That's now part of all stroke units, and involves measurement of hypoxia, temperature, hypertension, and assessment of complications and deterioration of the patient. Preventing pneumonia is absolutely crucial in improving outcomes after stroke patients. Pneumonia massively increases mortality. There are a number of studies and meta-analyses, and numbers vary a little bit, but you're looking about in a patient with pneumonia. Yeah, hello. Having an increase of the rate of mortality 4 to 5 times. Pneumonia occurs in 8 to 11% of all stroke patients, but if you've got nasogastric tube, it goes up to 40%. And if you've got a nasogastric tube and gastroesophageal reflex, it's almost 90% of all patients with that particular combination of symptoms will have pneumonia. So it's common, it's most common in severe strokes with nasogastric feeds. Because of that, because it's so common, one idea was to prevent it by just giving preventative antibiotics. And there have been a number of studies listed here, but none of them, irrespective of which antibiotic was taken, showed any benefits. They did manage to reduce UTIs, but not pneumonia, suggesting that maybe the pathophysiology of pneumonia is not purely infective, but there are other elements there. So how to prevent pneumonia? As I said before, dysphagia screening is very important. Positioning the patient, unconscious and semi-conscious patients, in the recovery position so that they can drain their secretions. Suctioning out secretions when the patient can't swallow and has got audible secretions. Mouth care is crucially important, because what's in the mouth is going to be aspirated and swallowed. So having a clean mouth helps to prevent pneumonia. As I say, early mobilization is important. And there may also be medical approaches. And these medical approaches are both drugs to give and drugs not to give. We've been involved in we have had a small pilot study of metoclopramide, which showed that it reduced the risk of pneumonia by 69%, but it was only 60 patients. And we're now running a bigger study with 2,000 patients to confirm this and see that it also reduces mortality. Other drugs which show promise was kilostazol, which is an antiplatelet agent, but seems to affect pneumonia risk as well, statins and ACE inhibitors. Drugs to avoid are proton pump inhibitors that increase the risk of pneumonia, and other acid suppressive drugs, beta blockers, and sedatives. My eighth point, and very important point in stroke unit care, is to avoid urinary catheters. It's been underestimated how dangerous they are. There's been a recent study from the South London Stroke Register, which has demonstrated that presence of a urinary catheter doubles mortality irrespective of other comorbidities and when these have been controlled for. That is because it increases the risk of urinary tract infections, it increases the risk of urosepsis, it increases antibiotic use, and by increasing antibiotic use, it increases the prevalence of antibiotic resistance, which turns into a vicious cycle. Preventing thrombosis, I'm not quite sure how high that is on the list of priorities in Hyderabad, but in the UK, it's very highly on the list. We have to go through the ward and tick a checklist every morning whether we've prescribed VTE prevention for all our patients. And if we don't do that, our managers come and get us into trouble. If our patients get thrombosis in spite of having prescribed it, and then there is a serious incident investigation for every single thrombosis. So thrombosis prevention is very high on the list in the UK. Simple things are giving aspirin, hydrating the patient, early mobilization, and then fully evidence-based intermittent pneumatic compression. The CLOT study in 2013 has shown that this particular intervention, and I've shown the sleeves here, not only reduces venous thromboembolism, but it also reduces mortality and after stroke. Because of that, it is recommended as the first choice, both in the European and in the American guidelines. I haven't consulted the Indian guidelines, so I'm not quite sure, but maybe in the discussion we'll find out what the guidelines are locally. I can imagine that wearing these stockings must be pretty horrible if it's hot outside. What is not recommended in the UK and is only recommended with reduced evidence is prophylactic anticoagulation. Although if you speak to physicians in Europe, this is used quite a lot. The reason why there are problems with this particular intervention is that it's very effective at reducing DVT. And there's lots of studies which show that prophylactic anticoagulation does reduce DVT. But most of the DVTs prevented are asymptomatic DVTs. And there is no good evidence that it reduces PEs, or not very much. And that partially is because the PEs are so rare. If you then tot up the numbers of PEs prevented against the numbers of brain hemorrhages which occur because of anticoagulation, this particular systematic review has shown that the numbers of PEs prevented are exactly the same number as the number of hemorrhages produced. So plus minus, there's no overall benefit. And that is why in the UK we're not using it. You can't say no overall benefit means no harm, so you can do it if you must, but it's not doing the patient any overall good. Another important aspect is avoiding premature treatment decisions, and those are often treatment limitations. There are lots of prognostication factors for stroke, which say which patients are likely to survive and not. And if you act on those and restore treatments early in particular high-risk patients, you'll find that mortality and overall outcomes are worse. And there are now a number of studies which actually shown that. And I've got the references here. Education, absolutely crucial for stroke unit care. That involves training of all staff, not only the doctors or the nurses, but also the health cares and everyone else who comes in contact with a patient with the basics of stroke care. I've just listed a number of interventions here. And I've listed a number of sources here. There are now quite a lot of web-based training programs, but basically, in my experience, ward-based training programs where you actually speak to people and have a multidisciplinary team present so that you can discuss questions and answers is considerably better than any web-based learning program. And last but not least, I think stroke research is absolutely crucial. It's well known that patients who are in clinical trials, and that whether they're in the control group or in the active group, have better outcomes than those patients who are not in trials. Furthermore, stroke units which are actively involved in providing research and enrolling patients into trials provide a better service overall for patients and have got better outcomes. That should be enough to say that stroke research is really important, but of course, we will get new and better treatments with research. And that applies for both the positive studies and the negative studies. So I was involved in the stroke oxygen study. I was the chief investigator of that, which showed that prophylactic oxygen is not necessary. So we can concentrate on something else. Other studies, like the thrombolysis studies and thrombectomy studies, have given us a new treatment. So whatever the outcome, research helps. So in conclusion, to make the black box of stroke care a little bit whiter, it's simple things which make big differences. Prevent stroke recurrence, prevent complications, start mobilization out of bed early, ensure all members of the team are trained in stroke, and include research into daily practice. Thank you very much for listening.
Thank you, Professor
Hello,
Christine.
is there anyone there?
That was very helpful. Yeah. And could you please stop sharing your screen?
Yeah, I will stop sharing. Yes, I've got that one.
Now, Dr. Sanjeev, we'd like you to take us forward into the discussion.
Thank you. Yeah, thank you for the invite. Can you see my screen? 1 second. Can you see the full screen now?
Yes, we can.
Okay, thank you. I'm going to speak briefly about mechanical thrombectomy. I'll keep more time for discussion, so I'm just going to whiz through my presentation and probably go through some of the ones which are not not that important. But the idea of this presentation is to give you, the audience, an idea or a brief introduction to what mechanical thrombectomy in stroke is. Now, basically, this has revolutionized the treatment of large vessel stroke worldwide. For every 100 patients, 38 patients will have a less disabled outcome with a need to treat of 2.6, and 20 more achieving a functional independence. It's one of the highest NNT throughout medicine. And recent trials have demonstrated that we can use further advanced imaging to increase the time into up to 24 hours in selected patients. So approximately 10% of the stroke patients can benefit from thrombectomy. And just to give you a brief introduction about what happened in the UK, we at the Royal Stroke University Hospital, I work with Professor Christine Roff, who is the professor of stroke unit, and with her we developed the first stroke thrombectomy service, 24/7 thrombectomy service in the UK. So basically, the importance of stroke, I don't have to go through this. It's the fourth common cause of death in the UK. Expensive because it causes disability and it affects the communities. 2/3 of the patients are above 65 years old, and mortality is around 17%, which is improving. So the importance of time in stroke is, for every minute of stroke, you are losing 1.9 million neurons. And this is just a map I've shown. For an hour of stroke, you're losing the distance in the UK between the Scotland in Dundee to London. So it's basically a lot of fibers are being lost for every minute of delay. Now, looking at the time scales, when the first PCI and the first
sorry to interrupt, Sanjeev, your slides are not moving.
Are not moving now?
No, no.
I can see it moving here. Just a second. Okay,
Yeah.
now
Can you just make it into full screen?
Yes, they're moving.
it's moving. Is
We're
it?
on the importance of stroke now.
Yeah, now
Okay,
it's moving.
You came up.
Is it moving now?
Yeah, it's moving.
Yeah.
Yeah.
Okay, thank you. Now, just coming to the timelines of between cardiac and cerebral and the cardiac reperfusion, the first ever series for using fibrinolysin in stroke patients was in 1958. IA intraarterial. That's way before 20 years before the first PTCA was performed for angina. Now, the introduction of PCI for acute myocardial infarction took off as early as 1980s, but the evidence for stroke and mechanical thrombectomy came only in 2015. So if you look at this, there's a considerable pace at which these two fields have evolved. Now, why was that the cause? Why is the different? Was the complexity of the cerebral anatomy, or what was the difference for these two fields to be such a big gap for them to evolve? I think the cardiologists were early adopters for the RCTs and in endovascular therapy, but a neurologist struggled with this methodology until recent years, when we have produced a series of evidence to show the benefit of thrombectomy. Now, this is a screen which I show to when I show my presentation. If you have a big, large blocked brain, and if you're hoping to put a little bit of brain powder, it doesn't really open up, does it? So you need something like this, where somebody mechanically goes in and removes the unblocking of the, unblocks the drain. So this is what we do as interventionalists. This is what I do in the brain when there is a blockage. This is what thrombectomy is. Now, in picture,
Sorry, Dr. Sandeep, your slides are not moving. I'm really sorry to interrupt.
Now, can you see
No.
it?
Now I can see
Yeah,
it. But
I think
it
you're
doesn't
probably.
move.
Okay.
We're now on the three Scalyx race.
Yeah. So, okay. I think
Scalyx.
what I'll do is I'll go in this way. This is better off than. Okay, I'll go with this. I think it's better than making it full screen and the screen disappearing. So now I'll show you thrombectomy in real what it is by example. So this was an elderly male patient who came in with sudden onset of right-sided weakness. The NIH score was 17. This was when this happened. This was filmed in a hospital. I want to show you. This is what what happened. If you just...
Royal Stoke Resource. She's been taken off her now. Okay. Have you spoken to the stroke team at all? Thanks, bye. Okay, we've got 4 minutes for the stroke team.
Right. He's got a very high stroke score. It's on the right side, and he can't speak, so it's a severe stroke.
Thank you.
Hi. Hi.
It's fine.
Okay. Look at this, Steve. You see my finger here? Can you follow my finger with your eyes? Can you try and lift this leg up for me? Put it up for me. Keep it up. Okay. Try and lift it up again for me. Steve, lift this leg up.
You're so fast. I don't even know where I am. It's all a massive shock. It just happened so rapidly. So rapidly. 1 minute he was all right. And
Now
then
lift his arm up for me again. Good to go.
still reeling from it, really.
Okay, you've got a dense hemiplegia. He's pretty much aphasic.
So he can't move any of his right side. He's completely weak. Can't speak. So you're very serious. Yeah. So this was a patient who came in with a massive stroke. Now, just to give you an idea what thrombectomy is all about, we also do this imaging where we use artificial intelligence or a software which measures which part of the brain is actually viable, we can salvage, and which part of the brain is actually dead. So red means it's bad, green is blue. So in this case, there was a lot of brain that could be salvaged. So we decided to go for thrombectomy. Now, if you look at this, is what thrombectomy is about. This is the the in angiographic pictures. You can see there is no flow. If you look at this is the skull, there's no flow going into the brain. There is the flow cuts off at the very base of the skull. So there is no flow going into any of the intracranial vessels. So this patient has got a complete occlusion of the carotid artery with no flow going into the brain vessels. So following this, what we did is we took a catheter into the brain and then placed a stent and we managed to get this clot out by pulling the clot out. And by pulling this clot out, you can see that entire circulation is now maintained back. So this patient, who was featured in that film, he made his NIH score was 17. It came down to 2 at discharge, and MRS on discharge was 0. So he made a good recovery, this patient. So this is as effective as you can see the thrombectomy is. It really changes lives, saves brain. So saves. So if you look at the trials, if you look at the series of trials which took place since 2015, the number of trials came up, and you can see all these trials showed level 1 evidence in favor of thrombectomy, when compared to the best medical therapy. Now, if you look at the trials, there are more than just under 2,000 patients, which showed the range, which showed a significant better outcome in the thrombectomy group. The need to treat for one patient to be alive and independent was in the range between 3 to 7. But the most important thing was there was no increase in mortality, saying it was a safe procedure when compared to the best medical treatment. Now, with the evolution of what you call more advanced imaging and use of artificial intelligence, we can also offer thrombectomy up to 24 hours now with this new trial, the recent trials, which is the DAWN and the Diffuse 3 trials, which shows in select group of patients under certain criteria, we can offer the thrombectomy up to 24 hours. So things are evolving and things are changing. And comparing mechanical thrombectomy with some of the other medical treatments, now for mechanical thrombectomy in stroke, the need for treatment is between 3 and 7. If you compare it with carotid endarterectomy for severe carotid stenosis, the need to treat to prevent 1 stroke is 26. And the same for the PCI, when you compare it with systemic lysis, to prevent 1 death in acute coronary syndrome, is the need to treat is 30. So if you look at it, mechanical thrombectomy is just 3 to 4, need to treat. So it's one of the most powerful treatments which is currently, available in modern medicine. So, but however, the problem is the thrombectomy has still not evolved. If you look at this is the map of the world, red is bad. So all the red are the countries where the thrombectomy isn't yet developed. The green, the blue are the ones which have shown some progress. You can see it's most of the Europe and some parts of the US, and are showing good results. But UK and rest of the world, even UK is not, we're still slowly progressing, but rest of the world is still not the treatment has not been widely accepted, or there may be various reasons for the treatment not to be available in these places. Now, just going to a pathway, what is required for this stroke service, because this is very relevant, because I think a lot of centers in India are trying to develop thrombectomy services. I think there are places which are very patchy. It's not a service which is available everywhere. It's in certain big centers do offer these services, but this is something which has to be, the Indian healthcare system has to look into, especially looking at their national stroke strategies to see this treatment is available for everyone. Now, looking at the pathway, you have an interventional neuroradiologist, you have a stroke physician, an anesthetist, and an anesthetic assistant, a nurse and a radiographer, which are the part of the team which performs the procedure, or essential people for the procedure. We perform imaging. We do the initial imaging as a CT head, followed by a CT angiogram to look at the arterial anatomy of the brain, to look where the occlusion is. Following which we do CT perfusion. CT perfusion shows which part of the brain is viable and which part of the brain is actually dead. So we use the perfusion imaging for that. And in certain cases, we also use MRI, but not very often. So now with the use of artificial intelligence, we can, it's an automated software which picks up the area of the brain which is infarcted and also shows the area which is viable. It also shows the level of occlusion. So it all gives, you don't need a radiologist to actually report this. All you need to do is install this software in your hospital, and this software will show you everything. It will give the information that you require. It helps kind of speed up the process for the treatment. And this is particularly useful especially in a country like India, where where we are probably the resources are a bit scarce when it comes to manpower in certain smaller hospitals. This software will really help in diagnosing those patients and probably speeding up their treatment by making the referral pathway or referring them to centers which do offer this treatment. Now, coming to the pathway itself, the patient should be fit for the procedure. There are certain clinical criteria which I have mentioned here, which they should meet. for selection for thrombectomy, and the procedure is usually for the best patient outcome. It's done within 6 hours, for the best outcome. Certain cases we can go up to 24 hours, but the patient to benefit from this are very small. For posterior circulation, yes, you can extend the window up to maybe 12 to 24 hours. Now this is how we do the thrombectomy. I'll show you in pictures. This was a 67-year-old male. This is the artificial AI software which we used. This patient came in with left-sided weakness, aphasia, and left facial droop 3 hours after symptom onset. NIHS score was 12, and you can see here, you can see there's occlusion of the middle cerebral artery, and then you can see the brain parenchyma, and the advanced imaging did show there were further areas which could be salvaged. This is what thrombectomy is about. You take a catheter to one of the arteries in the neck, the carotid artery, you inject the dye, and it will show you a cutoff here. Following that, you take a smaller catheter, what we call as a microcatheter, through the occlusion, and you place a stent across the occlusion or within the clot, and then you keep the stent for a few minutes for it to engage with the clot, and you pull it out, and you can see there is the occlusion is completely opened up. And this is what it looks when you get the clot out. Here you can see the clot has come out in the stent, in the device, and sometimes you get it in the syringe as well. So in this case, the patient improved and he made a good recovery. Also, you can use a simple, straightforward technique of sucking the clot out. If you see in this particular case, this was a basilar occlusion, the clot in the back of the brain, in a basilar artery, life-threatening condition. We just used a suction catheter to suck the clot out, and there you got the clot out. This is a big clot which came out following suction. So the various techniques you can use, but I'm not going to go through the techniques here. But the point I'm trying to make here is that it's very important that you treat these patients quickly. I'll give you a couple of examples. If somebody has got a heart attack with ST elevation, MI on ECG, and within first 24 hours, within first 12 hours, within the symptoms, they don't even do a cardiac enzyme. They take them straight to the lab to treat them. Now that's the most recent way of approaching this condition, because even the 15% of the patients we know may not even be treated because they may not have an MI, but the fact that they have an elevation on the ECG is good enough for them to be taken straight to the cath lab without doing any further tests. The same applies with patients with bacterial meningitis. Somebody who's coming in with bacterial meningitis, they do not wait for the blood cultures. They just go start them on antibiotics, because that the bacteria double every 20 to 30 minutes. And this can kill a patient if you wait for the test results to come back. But even today, in many parts of the world, including in the UK, we decide what is the best, what's the best way of diagnosing these patients. Do we need CT angiogram? Do we need a CT perfusion? We waste a lot of time doing a lot of things which are not necessary. The plain CT head is good enough, but we should approach this acute stroke in the same way we approach the other conditions, like life-threatening conditions. And this is as time critical as any other condition. So time to treatment is critical, and it trumps selection. You have to be very, very quick when it comes to stroke and providing this treatment. Now, just to briefly tell you about how the pathway was developed, we started off with a group of people, like-minded people like Christine, and we have a few other stroke colleagues who we got together, and we decided this is the right treatment. Even when the evidence wasn't there, we've got a few patients to act as stroke champions, to speak to our commissioning team. And initially, we used the funding within our departmental budget, and following which we approached our local commissioning group to provide funding on case-to-case basis. And then we started getting the teams from the vascular interventional radiology, which was already present for the trauma service. So we kind of piggybacked on their service, getting the nurses and radiographers from the vascular interventional radiology service onto to do thrombectomy, and we formed this 24/7 thrombectomy service by providing various incentives to the staff. Now, this is what the team looks like when it comes to thrombectomy. We have a number of nurses. We have stroke physicians on the rota. We have interventional radiologists, neurological anesthetists, anesthetic assistants, radiographers, and nurse. And we have at the moment a 30-bedded stroke unit with, I think Christine has spoken about it anyway. And together we form with this team, we are able to provide this 24/7 thrombectomy service. We also offer this service to our regional hospitals. A number of regional hospitals also provide in a hub and spoke hub and spoke manner. So this is what I wanted to emphasize, especially in India. This might be very relevant if you have a big hospital, like say in the middle of in a city, like a big central hospital. The surrounding hospitals can feed the patients into the middle in this major hospital for thrombectomy. So pathways and structures should be developed in such a way that you identify 2 or 3 hospitals in a city which are probably catering to a certain equally to all the population of that city and the surrounding areas, and you use the surrounding hospitals where the stroke patients come to actually diagnose and send them for treatment to the main hospital using the hub and spoke method which we use. Now the networks can be established via the neurosciences center or through and images can be actually viewed through the teleradiology or through radiology linking systems. Also important is to have a very good understanding with the ambulance transport to get these patients quickly to these hospitals. So clear protocols, clear pathways, and there should be what you call drip and ship facility available. And with this clear protocols, this thrombectomy service in a region can be achieved. This is our first series, which Christine and our colleagues we published, and this is the results of a first series, and this showed favorable and a very positive outcome with thrombectomy within our center. And we also worked with NICE to show the cost effectiveness, and this was way back in 2015, I think, when we showed by providing this service we show an annual cost savings of 2.4 million pounds every year to our trust in terms of saving the length of stay for the patients and also by reducing the social care costs. Number of the patients which have been treated are featured in some of our national press, which is good for publicity and raising awareness across with the public. Also, we got some national awards for doing this service over the years. Now, I'm just briefly going to stop now. I'm going to stop now. Before that, I want to emphasize on one factor. It's very important to have a strategy here. In India, I don't see there is a what you call as a national stroke strategy which incorporates thrombectomy. There has to be a comprehensive stroke strategy which involves patient engagement, prevention, hyperacute care, acute care, rehabilitation, looking at the workforce, staff education, which is very important, looking at the metrics, and all these things has to be factored in when you have to develop such a complex life-saving service. So this is a food for thought for. I think some of the people here are involved in strategy. So this is something for them to think about how they can take this forwards. Thank you.
Thank you, Dr. Sanjeev. That was very comprehensive. And now I'd ask the participants if they have any questions, they can unmute themselves and ask the questions. In the meantime, I have one question for Professor Christine. In your slides, you mentioned that percutaneous gastroscopy is to be done after 3 to 4 weeks. Any particular reason why we want to do it later, not earlier, if we are saying that the patient is already having stroke and he's going to need enteral feeding for a long time? So why to delay the percutaneous gastroscopy?
Yeah, I suppose it is because of the results of the food study, which showed that the outcomes for patients are worse. So patients who had early PEGs were more likely to have bed sores. They were less likely to return to normal swallowing. They were more likely to go to nursing homes, and they generally had poorer outcomes. And one does wonder why that is the case, because the PEG itself should not have these adverse effects. And it may be a cultural and health service issue, but certainly in the UK, we try to prognosticate for patients. So patients who can't swallow, who are generally have got big strokes, are unlikely to make a full recovery, and very often require nursing home care. And the hospital decision then is that they can be discharged to a nursing home when they've got a nasogastric tube, but they can be discharged to a nursing home if they've got a PEG tube. So you can achieve faster nursing home discharge if you have a PEG tube. And I think that is why the outcomes were worse. So it wasn't actually the tube which was the issue, but it is that care changed from trying to rehabilitate the patient, from trying to get the swallow back, to just moving them out to a different environment. And I suppose the point I was trying to make there and in the other slide is that early prognostication is not good and not in the benefit of the patient. In that case, it was an unexpected findings, but there are now more studies where we look at that sort of thing, most recently in brain hemorrhage, where again it was shown that if you prognosticate early and withdraw treatment, active treatment, outcomes are worse. That's not only that the mortality is higher, but it's also that the people who recover have got who remain alive have more disabilities because you're missing out on proper care at the beginning.
Thanks, Professor Christine. Now I'd like Dr. Kiran to take us with his presentation.
Can you see the screen? Okay.
Yep.
Yeah. I am more or less my presentation will be a wrap-up slides because I am not a stroke specialist and let alone neurologist. But I would like to put the whole presentation in a context why this happened, because you know, Sanjeev Nayak is my good friend and an old classmate, and I'm proud that you know, he has done what you all see. But what inspired me for this was his drive to establish the stroke unit. That was what inspired me, and which is of course very necessary in a country like India. And also when I was thinking in our context of consortium, where we need to connect different people, some with you know, less in a region with less access, where we are using technology, especially telemedicine and others, to link up the specialist to the remote areas. I was just thinking whether is this feasible in a stroke, because that is close to many people and it's close to our heart. As a neuroscientist, it is just like any cardiologist would you know, consider an heart attack. We think brain attack or stroke is equally important, regardless of whether you are a neurosurgeon or a skull-based surgeon or a neurologist, anybody. The stroke is something which we need to consider, and our whole aim would be to reduce and prevent strokes. Okay, the next slide.
Yes, we can see this slide.
Yeah. That's the most important innovation or can expect in a stroke, perhaps is prevention of the stroke. So there is a level of mastery which many of us know in martial art. The questions which was asked to Bruce Lee in Enter the Dragon. So one of the ways of the mastery is first is the level we all know, and the next level use and you know, where you don't need to bring it, or you can take it with your tactics of speech and management and other things. And higher level to be using the heart, where you need not have to use any of these tactics, just in the by your presence itself, anybody can to change his mind. And the last and the highest would be where there is no enemy at all. And similarly, I think the aim of any medical treatment would be ultimately to see that there is no need of treating that patient. So that would be the highest. So we can have a primary prevention where stroke itself, the chance of having it is reduced. And next is the secondary prevention, where the recurrence of the stroke is reduced. So some of the preventable cause, even in young, is supposed to be these. That is high cholesterol, that is the fat food we know. Second is smoking. As much as 44% of the strokes can be reduced by just stopping smoking. This is how important the campaigning for stopping smoking is, and proper control of diabetes, high BP and others. These can prevent as much as 39% of the stroke. The primary prevention strategy of course, would be non-drug and lifestyle changes, quitting smoking, limited alcohol consumption, I would say no alcohol consumption, and reduced body weight, and you are increasing the exercises like yoga and aerobics, the non-weight bearing exercises, and adopting a healthy diet. Now studies are proving more and more that fruits and vegetables are supposed to prevent this. One of the things I was thinking, I got inspired, was the establishment of telestroke. I have seen a YouTube where, using telemedicine, a person from Himachal Pradesh, that is in a higher reaches of Himalayas, develops a TIAR, what is called as mini stroke or pre-stroke. That was detected by a nurse because she was, trained to do it. And then she connects through a telemedicine to Chennai. And then the option was whether to treat there or to take to a hospital, which is, at least 50 kilometers. And in the Himalayas, it will take at least 4 to 5 hours. And using telemedicine, the doctor says how to do it, what Dr. Sanjeev told, one of the thrombolysis, that is intravenous, through intravenous route, the thrombolysis. And using that, they were able to prevent the stroke. So similarly, whether these strategies can be used to establish mini stroke units all over the country, which can be linked with the telestroke or telemedicine, so that we can make a difference to the people. This is, I feel, is one of the new innovations, and as a consortium, we should look at this. And other new innovations which is coming is the stem cell therapy, where we can reduce the mortality or morbidity, to be precise, and help in recovery. But there are multiple issues which concern this. One is what type of stem cell to put, what will be the dosage, and what will be the route, whether you can give IV or directly to the brain, and to the patient, which phase, whether if the patient comes in acute attack, instead of treating all these, whether we should concentrate on stem cell or in a little later stage or in a chronic stage. These are the challenges which, as a scientist, which we are encountering. Some of the simple, surgical approaches which we have done, which we have perfected, is what is called as decompressive craniectomy. That means the whole brain is caged in a skull, which is acts like a unyielding, like a what you call a pressure cooker kind of thing. And once the pressure builds up in the edema, there is no place for the brain to expand after some time. So that itself will cause many complications. To prevent that, what we do is we remove a portion of the skull, and that will reduce the pressure. This simple technique, as many studies have shown, as I've quoted here, as reduces anywhere mortality from 52 to 88% if done early. But one caveat is this may not reduce the morbidity. That is how we need, but there are some studies showing even morbidity is reduced, but that more need to become. How it works is just by removing the skull, the pressure from 35 comes down as much as to 10, and further, just by removing dura, that is cutting the layer covering the brain, it reduces further by another 10 to 20%. This is how useful it is. And next is aneurysm. This is also one of the important cause of stroke. That means this is a different kind. When any patient comes with sudden onset of headache, that means there may be a chance that he may be having aneurysm. He will say, just like how a heart attack patient says, I've got a pain of my life, he will also say, I've got a headache of my life. Or suddenly the patient may collapse. In which case, what happens, there will be an abnormality in the blood supply to the brain, that blood vessel, there will be a small balloon-like outpouching, it would have leaked. And within good time, if it is not treated, the second leak may be catastrophic. In Japan, there are many aneurysm clinics. That means there will be some 5-bedded hospital, just like how our eye hospitals are there. They just treat only these aneurysms, nothing else they do. They have one or two good OTs, and other methods like cath lab and other. They just do angiogram, and then pick up these aneurysms even before they are become symptomatic, and then they treat one of these. This is one of the methods which they do it. And if there is a hemorrhage within the brain, there are different methods, right from the what I told, the decompressive craniectomy, that we can do. Otherwise, we can put an endoscope, that is a small tube and lens like telescope, and then go in and suck out the tube. This make help in the recovery, but there are no long-term study which shows that removing these hematoma will make a lot of difference. But if the patient has got too much of swelling or complications from it, this is one of the ways to do it. And the food for thought I would like to end my talk with it is stroke team, which is available 24 hours per day, 7 days per week, requires these specialties as was explained my previous speakers. This, as in many studies, have found to make a huge difference in the outcome of the people. It is not the sophisticated equipment per se, etc. And much of the interventional stroke treatment that occurs is now currently occurring outside the trial. Whether it may be beneficial or it may be not beneficial, we don't know. There is no way to collect the data, especially in a country like India. So a stroke unit and linking of these stroke units can probably analyze and provide a metrics to analyze studies whether any of these interventions will make a difference, and so that huge amount of public and private funding, whether is it needed. And as we know, many of these skills, there may be studies where they show intervention, when somebody does an intervention, there is a good outcome. But the medicine is as much art as a science. It is as much as a skill as just a data. So a person sitting in UK, like say our friend Dr. Sanjeev Nayak, may have very good results, but can we replicate here? And for that, training and interaction with these people and coming and seeing, in fact, even visiting these stroke centers may go long way to help sharing of this knowledge and honing the skill. And that is how we need to move forward. Thank you very much.
Thank you, Dr. Kiran. That was very helpful, and particularly the Indian context was very relevant. Just one question for Dr. Sanjeev. Dr. Sanjeev, you told us that the 6 hours, just like for MI, that's the ideal window period for doing thrombectomy. But in a country like India, we usually, Dr. Kiran would agree, we usually don't get a stroke patient within that 6 hours. So what do you suggest are the chances of having good outcomes, say up to, if we get a patient up to say like 20 hours or 24 hours post-stroke, what are the chances of a thrombectomy giving us results?
I think unfortunately, if it's 20 to 24 hours, it's not really good. But I think I had a colleague from US visiting me, and he said to me that patients in the US, they can't get in within 6 to 8 hours. They get 8 hours at least to get in one center to another. It's not very different from India. But for if they do offer patients thrombectomy up to 8 to 10 hours in US, the outcomes may not be the similar to what you would get in 6 hours, but probably it would be better than somebody having probably reducing the mortality or even reducing the level of disability. From that perspective, it may be beneficial, but you need to have advanced imaging for that. You need to look at perfusion imaging in that case. In those cases, I wouldn't recommend just doing on plain CT head, because if you do a thrombectomy or thrombolysis in those patients, they may bleed. They may have even worse outcome if you offer them treatment. So you need to have a specialized. You can't just offer this treatment without what Kiran just mentioned about having a specialized unit. You need to have the specialist around, a specialized team around you, and they should make that decision whether the treatment here, based on case-to-case basis, if they come, let's say 12 hours, maybe there are good collaterals and maybe their perfusion is still showing a good favorable for treatment, then you could possibly treat those patients. But I wouldn't randomly treat them. You'll be very careful in treating those patients.
And I think more to the point, setting up a service based on most patients coming late, you then spend a lot of money for mainly poor outcomes. So if you can't get patients reliably in within time, it doesn't seem worthwhile setting up a thrombectomy service just for the occasional one who gets through and has got an advantage. So the first aim would be to set up the infrastructure to get patients into the place. And when that is the place, then provide the treatment. But as I say, if you systematically, as Dr. Nayak said, if you systematically treat people late, you'll have lots and lots of poor outcomes. And you still would have spent all the same amount of money and resource on getting a really poor outcome in most.
Yeah, I completely agree with what Christine is saying. And that's one thing I think you have to work on infrastructure. What government has to look at is how, see, in India, the resources are not, there's no lack of resources. You know, we have hospitals which are well equipped, but they are catering to a very small, you know, niche population who can pay, and, you know, it's pay to pay basis system. So if actually government can identify, like I mentioned, like few hospitals within a city, maybe in different areas of a city, and then identify those satellite hospitals which can feed into them, I don't see why you can't have a robust service. Why the patients can not come in time? Patients do go to hospital, but the problem is a delay in the hospital systems in India. I've seen that delay in hospital systems has to be addressed. Somebody has to take a charge and see, you know, and look at those infrastructure rather than just getting the treatment and the facilities. I think the infrastructure is very important here.
I think what I hadn't
please go ahead, Professor. Yeah, please go ahead.
What I hadn't discussed with the stroke units is that even with the stroke units, it makes a difference how soon your patient gets to the stroke unit. So in the UK, we've got a standard that the patient should be within 4 hours of arriving in hospital, they should be on the stroke unit. Because everything is more efficient if you give it earlier. So if you're looking for buildings up something, it would make sense to build up a network of stroke units. And once you've got those, you can provide the other treatments quite easily. So it's thrombectomy and thrombolysis will come with well-functioning stroke services, or with an infrastructure which allows to get patients even if you didn't have a stroke unit, if you were to diagnose and direct them in the right place, that would make a big difference.
Yeah, and one thing that Dr. Sanjeev suggested, which is something which we as at EHAC and both in India, we should look forward to, is making a national stroke policy, or at least having some sort of stroke policy where we can actually do what Dr. Sanjeev suggested, that make up satellite hospitals, or, you know, smaller hospitals in smaller towns linked to, because we have big hospitals which have stroke units, which deal with stroke patients, and they have all the facilities. The thing is to provide them with patients in time for them to be successfully treated. I think Dr. Kiran would agree to that.
Right. One question I wanted to ask both Christine and Sanjeev is, what would be the utility of telemedicine or telestroke? Is it worthwhile to establish such as things, so that, you know, there is a lacuna in even diagnosing what is TIA or any of this, and then we can decide through the remote whether these patients are fit enough to be shifted, or some like IV thrombolysis and others. What is your opinion? Is it worthwhile to treat with those when the patients can't be shifted, or what is the study say?
Shall I, Christine, do you want to take this? I mean, I'll just briefly tell you my view. Christine may chip in later. I think it's, in a country like India, Kiran, I think it's very important. I think that's a start, at least, having a telemedicine and telelinking, because, you know, at the moment, there is no, you know, two hospitals, they don't talk to each other. If you have a center which can provide the facility, and if you can communicate with these centers, you know, have a communicating network. Communication is vital for this kind of treatments. So if you can develop, at least to start off with a telemedicine, that's a brilliant start. At least that's a start. And then you can think of further things like, you know, getting the infrastructure and, you know, getting the patients for thrombectomy and other things. But at least to start off with, I think the telemedicine and linking with hospitals, I think it will make a huge difference. That's my view. Would you agree with that, Christine?
Possibly. It depends on how you do it. Because we've gone through this step in the UK through having telemedicine, and I think most hospitals eventually got themselves their telemedicine trolley and for communication. I don't think it's worked very well in many places. What it does do is you, through telemedicine, you create a network. So we did that as well with our surrounding hospitals. Apart from that, we never turned on the telemedicine monitor, because you have to go to the monitor, you've got to turn it on, the other one side has got to turn it on. So we found that we actually communicated through mobile phones. So you have a patient and you see them at the other end and you want to advise them, and basically you turn on the mobile phone and say, show me your screen. Oh yes, hand, look over there. Can you just get that patient to wave their hand? And so I think we need to go to more direct technologies. There are nowadays technologies and programs which will allow you to do that. But in a low resource environment, you may find that you can use the resources you have already, i.e. your phones, to communicate together with an infrastructure where you know whom to phone and when. So you have to have an on-call rotor, you have to have people who are around and will be answering. But what form? I think it's not the technology which should be leading, but it's the network of people which is important. And the tools should be cheap and easily available. Because by the time we bought a telephone network, and by the time we got it, it was already out of date.
Mm. And also one more thing, I think knowing the way Indian infrastructure is, it's very important. This thing should come from the government. Government should be, driving this with the, individuals like Kiran can drive this, but the support he'll get is probably very patchy and local, with a few hospitals. If you want this to be fast and throughout a state or throughout the country, then it has to be driven by the government, and government has to understand the impact of stroke. So that is where I think you need to campaign. You need to provide, you should get the campaigning whichever way you can, with media or with getting important personalities involved and making government hearing your voices, making them aware that they have to pitch in something for the infrastructure.
Certainly, what started it off in the UK was actually setting up a national audit, so that all hospitals and all patients were being included in a registry. And suddenly you can compare outcomes between different hospitals, and that makes a difference. It creates some sort of network of people. And I think the research network there helped as well, because we have the national audit for the outcomes, and we have the research network, which connected clinicians. And together of that, you do bring, you can create structures. It's better if it's national, but it's probably faster, and a lot of it starts off local, and then the national trend will pick up what works best of a number of local approaches.
I think there's one question. Shweta, you want to ask a question? Yeah.
Mr. Sharad Iyengar, would you like to ask the question yourself?
Sure. I am Dr. Sharad Iyengar. I'm a public health physician, also trained in pediatrics. Curiously, I've just come back from a 480-kilometer bicycle ride through interiors of Himachal Pradesh, where I found that the nearest hospital often was 350 to 400 kilometers away, and you can assume that it would take 10 hours to cover such distances. There is therefore, I'm trying to understand what infrastructure means. Maybe it means roads. Wherever there are roads, there's quicker transport, and maybe there are vehicles which can transport patients quickly to hospitals. But when we talk hospitals in such a scenario, we are talking of district hospitals staffed by general doctors, not specialists. And even if they are specialists, they'd be the basic specialists like surgeons, maybe a physician, an internist. And therefore, my question, we keep talking of a stroke unit, and then the cardiologists talk of a cardiac unit or an intensive cardiac unit. There are similarities in the procedures. Is it or is it not feasible or viable to test a single unit that can deal with acute myocardial infarct as well as stroke, and maybe even other similar vascular events, perhaps pulmonary embolism or other events, so that we optimize the use of resources? I do feel that far more important than, or equally important as infrastructure is how well human resource teams are equipped and trained to deal with multiple emergencies. Otherwise, I think in a country like India, in the hinterland, a stroke unit, which doesn't do anything other than deal with stroke, is a bit of a pipe dream. So I'd like, I mean, the panelists to respond.
I think it depends obviously on how small your population is. If you're looking at stroke units, we've got, if they're less than 500 patients admitted a year, they're not going to work very well. No. So if your population is that sparsely distributed so that you're getting fewer patients, you will have to have smaller units or joint units. And for that, I would go for the interventions which work best. So again, I think you do have to have a specialism. So if you think about my stroke unit talk, so what is really important in that? Diagnosing your stroke, giving the aspirin straight away, already gets you a lot of gains and doesn't cost a lot. If you've got a CT scan and you can give thrombolysis, you've got something gained. If you can then test for swallowing, and that would make a big difference. So even if you only implemented those three things, and on a cardiac unit, obviously they'll know how to measure a pulse and a blood pressure. So well, that's not an issue either. So yes, you'd look for the most important aspects of that unit and try and keep it. The thrombectomy, I think you need to do enough of them to be good at it, and that means having bigger units. But thrombolysis is something which can be learned, and which can be done in smaller units. So I would go for that.
I think very nicely put in perspective by Christine. We have two things to concern. One is a stroke unit, which we can call as a basic stroke unit, where the prevention and probably initial treatment takes the predominant. As she has rightly put it out, simple steps like giving aspirin or IV thrombolysis, like the YouTube presentation which I told, where a patient in higher reaches of Himachal Pradesh in Himalayas was immediately given this option of thrombolysis, because that was medicine was available, and the staff nurse was trained mainly primarily for the cardiac. But because the doctor was available through telemedicine, he could be able to give, tell her the dosages and then watch the patient for some time. And then once the medicine is done and then there's no complications, he was shifted to a higher center for further care. So this is one. This is there, and as Sharad Iyengar has told, this can be combined with many district hospitals. Now, I think you may be surprised, many district hospitals and even taluk hospitals have access to CT scans and many of the higher ends, especially with respect to cardiac and other things like a cath lab and other facilities. So that can be utilized for a stroke unit, and then maybe the higher, that is thrombectomy and others, we can use it for a separate, what we call a tertiary care unit or a thrombectomy unit. So I think maybe we are looking at a stepwise pattern in these two.
And I think just to add to what Christine said with Dr. Iyengar's question, I think if you look at the way the Indian healthcare is spread out, like for example, Kiran's hospital has got thrombectomy facilities. They got state-of-art neurosurgery, neurovascular, and everything is there in that hospital. But when it comes to the hospital which Dr. Iyengar spoke about in Himachal, there may be nothing in those hospitals. And that's where the importance of linking through either some source, either you have some form of telephone, kind of apps which can communicate with each other, or you use telemedicine is a broad term. So you can use that some form of communication, either the modern, you form an app, develop an app particularly for Indian healthcare system, which everybody's got a smartphone nowadays. So everybody can put that app on the phone and communicate with that app rather than using something like WhatsApp, because it's too complicated using WhatsApp in a big perspective like this. So if you develop some form of an app whereby you can communicate with doctors, with the healthcare systems, that might be at least a start in smaller centers, especially in smaller centers in India.
Now, I'm in full agreement with what you're saying about telemedicine and about training and guiding primary care physicians. The point I'm making is we keep saying stroke unit because we got used to saying it. I mean, there's going to be another one for road accidents and a third one for cardiac care. All I'm saying is that the same doctors, surgeons, physicians, not just nobody there, with trained nurses would be handling multiple conditions. And I think we've got to get used to the idea of strokes being managed by a team that also manages other conditions and not keep insisting on specialized units all over the place. Specialized units are very expensive. They work only in very large cities. And that'll exclude something like 3/4 of India, and that's a huge country. So all I'm saying is we've got to start thinking in this direction of having one team of people trained to do multiple things. And I'm okay. I appreciate the fact that a bunch of neurologists will not be able to comment on what you can do on the cardiac front or on the road trauma front. But I think this is what calls for multiple specialities to come together.
The problem, Dr. Iyengar, here is this is a good concept. What you're saying in concept, it is good. But how is the training in India doesn't support cardiac and neurology and trauma at the same time? We don't have specialists who are trained in that particular way in India. You have people trained in stroke, you have people trained in cardiac, you have people trained in trauma. So one person doing all three, we don't have that training set up from what I understand, that doesn't exist.
I completely agree with you. I don't think there's any such entity even in the UK. That's because our specializations are siloed in this manner, and that acts as a barrier. And I say this as someone who's working at the primary care level for now a few decades. You know, we've got to think out of the box and move in that direction. I'm not saying it's readily available. It's just that we've got to move that way.
I think what Dr. Sharad is trying to put in for the Indian perspective at the primary healthcare level, we need to have people who are trained in multidisciplines to manage multiple things. They may not be specialists, but at least they can manage the basic things so that the patient's immediate life is saved, or just like Dr. Christine said, we can at least give him aspirin and thrombolize and then stabilize the patient and refer to a tertiary center, because usually the majority of Indian population does not reach a tertiary care center or a secondary care center. We have to have people at the PHC level to at least, just diagnose it maybe, or maybe just try to give supportive care. Even that we don't have. Right, Dr. Sharad? That's what you wanted to say?
Shweta, you do have specialists. That's the point I'm trying to make. There are physicians, there are surgeons, there are pediatricians, there are gynecologists. That's what the government is trying to do. And if it can pull this off at a block level, a block is about 200,000 population. I mean, it's done something. These are people who've done 3 years of residency. Now, the point is whether they could be constituted into a multidisciplinary team that at least looks at the commonest causes of acute mortality. That's the small point I'm trying to make.
Duly taken. With that, I would like to close up. And first of all, I'd like to thank all the panelists for taking time out of your busy schedules and enlightening us. It was a very enlightening discussion. We gained a lot of insight, and I think it would help us. Dr. Kiran would agree that, we can try to make some sort of policy or, create noises so that at least the government takes this into perspective that, stroke is important and it needs to be treated. So yeah, thank you so much for your time. And thank you all the participants also for listening. And Dr. Sharad, you too, for raising a very valid point for Indian healthcare. Thank you all.
Thank you.
Thank you. Thank you.
Thank you.
Bye.
Bye.